Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam. I'm a cardiologist from Houston, Texas, and today we are going to be talking about EKG interpretations. This is based on my book, Clinical EKG Interpretation and Patient Management. You can take a look at this book on Amazon.com, and also please visit our YouTube channel and watch chapters on introduction, conduction disturbances, chamber enlargements, and bradycardias. In this presentation, we are going to be talking about one of the most important topics, supraventricular arrhythmias and their differential diagnosis. This is extremely useful. All those providers who deal with supraventricular tachycardia in the emergency room, in the intensive care unit, or in the CCU, or perhaps for that matter in any urgent care centers. So grab a cup of coffee, sit down, relax, and enjoy the rest of the presentation. So let us begin. Supraventricular arrhythmias. All the arrhythmias arising from the sinus node all the way up to the AV junction. Anything below the AV junction is not covered in this chapter. We'll be looking at some of the ectopic beats, namely atrial bigeminy, blocked atrial beats, sinus tachycardia arising from the sinus node, paroxysmal supraventricular tachycardia arising from any part of the right or the left atria. Then we're going to look at the AV junctional rhythm, AV junctional tachycardia. Next, we're going to look at the atrial fibrillation, atrial flutter, multifocal atrial tachycardia, and also WPW, type A and type B. Throughout the presentation, we are going to be covering some of the latest recommendations from the ACC/AHA guidelines for acute and chronic management of supraventricular tachycardias. Next, take a look at this electrocardiogram. Write down all the findings that you see, then we will proceed. Here we have V1, lead 2, and V5. Okay, let's focus on lead 2. We have a sinus beat here, we have a sinus beat here, then we have a premature narrow complex beat. Following that, we have 4 normal beats and a premature beat. And if you look at the T wave here, which looks quite different from the previous T wave, meaning probably the atrial activity is embedded within this T wave, giving this peaked appearance, and so we are dealing with premature atrial beats. Could these be junctional beats? If the T wave morphology was identical to the previous T wave, then we could say this could perhaps be AV junctional beat, but since there is some deformity of the T wave or change in morphology of the T wave, this is most likely a premature atrial beat with a compensatory pause, thus resulting in a longer RR interval compared to the regular underlying sinus rhythm. That is a premature atrial beat. So let us continue. Take a look at this electrocardiogram. Write down your findings, then we will proceed. I would like you to pay attention to this little chart I have created, which is going to be the most useful part of this entire supraventricular tachycardia and differential diagnosis of a tachycardia presentation put together. So I will go over this and I'll show you what is the importance and significance of this underlying fundamental foundation that is going to help you to decipher any type of a supraventricular tachyarrhythmia and come to a logical conclusion, and then make a decision on what is acute treatment and what are the drugs of choices on the long run. Okay, let's look at, we have here 1, 2, 3 major boxes. Approximately it is 15 boxes, so the heart rate is 100. If you have 14 small boxes, it is 125. If you have 10 small boxes, it is 150. If you have 9 boxes, it is 166. Then it goes to 187, 214, 250, and if you have only 5 small boxes, that is 300 and 375. We have 4, like from here to here, if you have 4 small boxes. You need to memorize and imprint this image on your brain cells. This will give you a quick rundown of what is the rate you're dealing with. That is the first and the most important fundamental thing we have to establish when we are talking about differential diagnosis of supraventricular tachycardia. So we have a heart rate of 100. We have sinus beat, sinus beat, sinus beat, and now look at this one. There is what looks like a P wave blended with the T wave, but there's no Qrs complex compared to the previous electrocardiogram we saw. So this is a blocked PAC. Could this be a blocked junctional rhythm? If it's a junctional rhythm, as I said, you don't see P waves, so this is not a junctional rhythm. Whenever we see a P wave between 2 normal P waves, you always wonder, are we dealing with a Venki block? Are we dealing with second degree AV block? Is this Mobitz type 2 AV block? How do we differentiate that? Well, first of all, in Mobitz type 2, the PP intervals must be constant. If not, then we are dealing with something different. Here, if you look at the PP interval here and the PP interval here, this is short. That means this is a premature beat. Second, we see a compensatory pause, which is not twice the cycle of a regular sinus rhythm. So this is less than multiples of PP interval. So that is what we can deduct from this. But I want to emphasize more importantly the differential diagnosis every time we are talking about a given rhythm, so that we understand this from multiple angles, not just focusing on trying to make the quickest and the most accurate diagnosis. Okay, take a look at this and see what your diagnosis is. Okay, we have a sinus beat here. Following that, we have a premature atrial beat. Why do you call this premature atrial beat? Because there's a P wave and it is falling right close to the T wave. So the next normal sinus beat should not be coming close to the T wave. So obviously this is a premature atrial beat because this is a narrow Qrs complex which resembles the previous sinus beat. And interestingly enough, every other beat is a premature beat. So here we are dealing with atrial bigeminy. What is the underlying rate? We don't know because we don't have a strip where we can see 2 consecutive sinus beats, but this is the effective hemodynamic heart rate. So this is what matters. If you are having PVCs, for example, those PVCs are ineffective in generating stroke volume. As a result, this would be considered for practical purposes significant functional bradycardia. Okay, let's move on to the next one. So take a look at this rhythm strip and see what you find, and then we'll proceed. Again, let's look at the heart rate here. It's kind of hard to see how many beats are there. I would say it's from here to here is 4, so this is approximately like 100 heart rate. Anyway, we have sinus beat all the way up to here. Then we have what looks like a different morphology. And number 2, this is premature because it is happening before the next P wave is due. In fact, we don't even see a P wave here. We have a Qrs complex, which is slightly less than 120 or maybe 120 milliseconds, but the initial deflection looks very similar to the sinus beat. Since we don't see a P wave, since this is a premature beat, most likely this is a premature junctional beat with some kind of ventricular aberration because the Qrs interval is almost 120 milliseconds. Let's move on to the next one. Now, tachyarrhythmias. The supraventricular tachyarrhythmias can have 2 types of origin. Either they can be arising from an automatic focus which simply fires without any relationship to the rest of the cardiac rhythm, and it has its own rate. It is not interrupted by any other electrical activity in the heart, and that leads to rapid heartbeat with a narrow Qrs complex. The supraventricular arrhythmias, which are automatic in nature, include paroxysmal supraventricular tachycardia, sinus tachycardia, junctional tachycardia, and multifocal atrial tachycardia. We're going to look at each one of these examples and go through, most importantly, how we decipher the most logical diagnosis and how we differentiate that from all the other conditions in this particular category. The second type of arrhythmia which we encounter is called the Reentrant Tachycardia, and the Reentrant Tachycardia happens when we have an electrical system such as in the AB node, where part of the AB node is blocked as the impulse is coming down. So the impulse goes through pathway 1, then it goes through pathway 3, then now it finds the pathway 2, which is part of the AB node, able to conduct retrograde. So it goes there and it sets off a circle, a continuous cycle. That's what's called the reentrant tachycardia. This reentrant circuit can be anywhere in any part of the heart. It can be in the walls of the atria. That's where we see patients with WPW develop wide Qrs tachycardia due to accelerated conduction through the accessory pathway. Or sometimes the reentrant tachycardia can go through the AB node, which can lead to AB nodal re-entry tachycardia. Sometimes the impulses can go from the atria to the ventricles through other accessory pathways and create atrioventricular re-entry tachycardia. Some other examples include atrial flutter, atrial fibrillation, then we have the AB nodal re-entry tachycardia, and then atrioventricular re-entry tachycardia. We're going to look at each one of these examples and also talk about what is the best way to treat these various types of supraventricular arrhythmias. Okay, here is a different way to represent. Here we have an ectopic focus which randomly fires. In case of atrial tachycardia, it's generally a single focus that fires the impulse. It goes through the AB node and it keeps firing. It is not interrupted by any other electrical activity going on through the heart unless some impulse or some other physical or pharmacological maneuver breaks this cycle and calms this excited focus. And re-entry tachycardia we talked about. It could be in the AB node as it is depicted here, and in the future part of this presentation we're going to look at these circuits going through the accessory pathways and other connections. What are some of the bedside maneuvers that we can use to differentiate various types of supraventricular tachycardias? When a heart rate is going at a rate of 200 per minute with a narrow Qrs complex where the P and the T waves are blended together, it is almost impossible to find out what is the origin of the supraventricular tachycardia. Some of the things that we can do at bedside can help us to slow the rate so that we can separate the T waves and the P waves and see what is the origin of the supraventricular tachycardia. One such maneuver is doing carotid sinus pressure. As you can see in the neck at the bifurcation of the common carotid artery, there is a carotid body located, and when we put pressure on the carotid body, it sets off a baroreceptor reflex which sends impulses to the parasympathetic system, which in turn sends impulses to the heart and the AV node to slow the AV conduction, which can unravel the mystery behind the tachyarrhythmia. There are some precautions that we need to take when we are doing carotid sinus pressure. First, we need to listen to the carotids and make sure there are no significant bruits. And number two, we don't want two people pressing on either side of the carotids simultaneously. Whenever we do carotid pressure, we should have a continuous ECG monitoring and perhaps ECG running so that we can document the effect of the carotid sinus pressure. Basically, the carotid sinus pressure slows the conduction through the AV node, thus revealing the atrial activity and helping us in identifying the mechanism of the supraventricular tachyarrhythmia. Valsalva maneuver also works in a similar manner. By straining, you are increasing the intrathoracic pressure, and that also leads to slowing of the ventricular response and unravel the mystery. If these procedures are unsuccessful, a small dose of IV beta blocker like 5 milligrams of low pressure or metoprolol given IV can slow the rate temporarily and help us to identify the underlying rhythm. The beta blockers given intravenously last for 15 to 20 minutes, and we want to make sure their blood pressure is adequate and the oxygen levels are adequate before we give intravenous beta blockers. So these are some of the bedside maneuvers that might help us to identify the origin of the supraventricular tachycardia, be it from an ectopic focus in the atria or be it from a circuit within the right atrium creating atrial flutter, or it could be multifocal atrial tachycardia. In all this presentation, I would say this is the most important slide that you want to remember for the rest of your life. This is the foundation based upon which you try to systematically analyze a given EKG or a rhythm strip to arrive at the most logical conclusion as to what type of supraventricular arrhythmia are we dealing with. Where does it arise and what does it mean? How do we differentiate between supraventricular tachycardia with the wide Qrs complexes with ventricular tachycardia? So let's begin. The moment we look at a 12-lead electrocardiogram or a rhythm strip, we should look at the P waves and the Qrs morphology. If the Qrs morphology is narrow, then we are dealing with supraventricular tachycardia. If the Qrs morphology is wide, then it could be either supraventricular tachycardia or ventricular tachycardia. Next, we want to look at the atrial and ventricular rates. It may be easier to measure the ventricular rate in patients with a very rapid heartbeat. However, if we don't see the P waves, it would be hard to measure the atrial rate. It is exceedingly important to measure the atrial rate because the atrial rate, if it is 1-to-1 conduction, it means something, and if it is 2-to-1 conduction, that has a different connotation. Hence, understanding the atrial rate and its relationship to the Qrs complexes is of paramount importance in trying to decipher the origin of the supraventricular tachycardia. Then we're going to talk about relationship between P and Qrs complexes. How many P's do we have for each Qrs complex? Is there a relationship between P and Qrs complexes? Is there an AB dissociation? Are the P waves normal? Are they retrograde? Are they hidden in the Qrs complex? So all these things need to be looked into to arrive at a proper diagnosis. We talked about narrow or wide Qrs complex and the P wave morphology. And it is also important, if we can, if at all possible, go back and look at the telemetry monitor strips and see what was the rhythm that initiated this tachyarrhythmia. What were the extra beats or change in the rhythm that initiated this? And most importantly, what terminates this arrhythmia spontaneously may give a great deal of clues as to what we are dealing with as far as the diagnosis of a supraventricular tachyarrhythmia is concerned. Again, symptomatology are exceedingly important. See, you just don't sit there and spend 2 hours trying to do a differential diagnosis on a supraventricular tachycardia if the patient is feeling dizzy, weak, low blood pressure, low oxygen level, pulmonary edema. The clinical presentation is of paramount importance in deciding what are we dealing with and how do we manage this, and then you can have a 30-minute debate in a conference room about the origin of the supraventricular tachycardia. So never ever forget the patient, because you are not only treating the arrhythmia, but most importantly, you are treating the patient. So focus on the patient with EKG as the reference. Then again, we talked about the hidden P waves in the QRS, T waves or ST segment, anywhere. Because when the rate is going so fast, there is not much diastolic period left for the P wave to hide. So you should look at any kind of deformity between the QRS complexes. That might shed some light as to the origin of the atrial activity. And of course, while we are focusing on the supraventricular tachycardia, we should also look at all other features which may also be of importance and which may give some clues as to why this patient developed this particular supraventricular tachyarrhythmia. If the patient has WPW, are we able to see delta waves? Does this patient have significant STT changes in chest pain? Is this myocardial ischemia that is triggering this supraventricular tachycardia? So all these things have to be put into this blender in the mind, and then we come up with a composite answer as to what is the most logical diagnosis, and most importantly, what is the next step you're going to take in terms of managing this acutely. And once the patient is stable, if you want, you can do electrophysiological studies to identify if you're dealing with the atrial flutter, and how to do ablation and get rid of almost 98% of the atrial flutter. Okay, let's continue. Here is a chart. It looks very complicated, but it's very simple. Let me explain this. If we have a narrow Qrs complex like what we are seeing here, and if the heart rate is between 100 to 160 with a P to QRS ratio of 1:1, the RR intervals being regular, P waves being upright, and the QRS being narrow, we are dealing with sinus tachycardia. Similarly, if the heart rate is 160 to 225 with the same type of features, or with a 2:1 conduction, we may be dealing with the paroxysmal atrial tachycardia, which is of an automatic nature. Next, atrial flutter. These numbers are very important. That's the most important thing. Paroxysmal supraventricular tachycardia, 160 to 225. Atrial flutter, 225 to 320. And with atrial flutter, I'm sure you have seen many tracings where you may have 1:1 conduction, 2:1 conduction, 3:1 conduction, or 4:1 conduction. The RR intervals can be variable. The P waves look like sawtooth, and the QRS complexes could be narrow or wide depending upon aberrant conduction or underlying bundle branch block. Atrial fibrillation, the most characteristic feature is the atrial rate is greater than 320. The P waves are not clearly visible. If they are visible, they are extremely small, narrow, and occurring very frequently. The RR intervals can vary. The QRS complex could be either narrow or wide. Multifocal atrial tachycardia. This is an important one, especially if we are dealing with patients with chronic lung disease or COPD or pulmonary hypertension, and their heart rates are between 100 to 250. And here we could have 1:1 conduction from the P to QRS. The most important characteristic with the multifocal atrial tachycardia is we do see P waves preceding each QRS complex, and these P waves are of multiform nature. The RR intervals can be variable, and the QRS complexes are usually narrow, and the QRS amplitude may also vary from beat to beat. Junctional tachycardia. The rate is 100 to 180 per minute. It is sort of similar to the sinus tachycardia, except that the P wave morphology will be a little bit different. Either we may not see the P waves altogether, or the P waves may be occurring before the QRS complex with a very short PR interval, or they may occur right after the QRS complex, producing a negative P wave. Then we have WPW, which is a hybrid of a variety of these arrhythmias occurring in the presence of accessory pathways. They can either have wide QRS tachycardia if the impulse is going through the accessory pathway, or they can even have regular narrow QRS tachycardia if the impulse is primarily traveling through the AB node. The most important feature in this case would be the delta wave in the QRS complex. So let us keep these numbers in mind. Sinus 100 to 160 beats per minute, SVT 160 to 225, atrial flutter 225 to 320, atrial fib, most of you know, MAT 100 to 250, junctional rhythm similar to sinus tachycardia 100 to 180, and WPW, WPW can produce atrial flutter, atrial fibrillation. These are the main types of arrhythmias it results in. All right, let's proceed. Okay, now, I talked about all the things that we need to look at systematically when we are dealing with a tachyarrhythmia. That's why I put this particular chart, which is a summary of the previous slide which I talked about the systematic approach, and we are going to use this template in looking at every electrocardiogram, trying to come to a conclusion as to what kind of supraventricular arrhythmia we are dealing with. Okay, let's talk about this. First of all, the rate. Let's look at the QRS complexes here. This is 10 boxes and 11 boxes. So 11 boxes will be approximately 10 boxes will be 150 and 10 boxes will be 150. This will be like 125 to 130. Or if you come from here, so if you look at here, if it were 10 boxes, then the rate would have been 150, but it is a little slower than 10 boxes. So it is more like 12 boxes. So it is approximately 135 beats. All right. So we have regular P waves here and narrow QRS complex. There is a one-to-one relationship between the P and the QRS complexes. There are some non-specific STT changes which we can see. So here we are dealing with sinus tachycardia. The rate is within the range of sinus tachycardia, and we have a regular rhythm, so there is no evidence of irregularity. Okay, let's look at this one. Here we have a heart rate. Again, we have 5, 6, 7, 8. If you look at 8, the heart rate is 187, and we have a sinus beat, P wave, QRS complex, P QRS. So there is one-to-one relationship between the P and the QRS complexes. The QRS complexes are narrow. There is no evidence of any extra humps in the T waves, so this is most likely one-to-one conduction. A heart rate of 187 puts this in the range of paroxysmal supraventricular tachycardia. The T waves look okay, the STT segments and the TP segment, they all look okay. So this is why I said this roadmap is so important in systematically recognizing the tachyarrhythmias. The more practice you do, the better it becomes. So let's look at another one. Now the heart rate is it's approximately 5 boxes here, small boxes. That means the heart rate is 300 per minute. So we have a narrow QRS complex. We have 300 per minute. Now we hardly see any P waves, which is not uncommon. And sometimes we may be able to see some changes in the PR segment that might give some clue, but here is just a rate of 300, narrow QRS complex. And this is where those bedside maneuvers come into play. And here with the carotid sinus pressure, we see the QRS complexes disappear due to the high vagal stimulation. Now we see the flutter waves. So that's one way to identify. If that doesn't work, we could use some intravenous drugs like beta blockers or adenosine to see if we can slow the rate, at least temporarily, to identify what we are dealing with. Are we dealing with atrial fibrillation or atrial flutter or MAT? I mean, of course, this is not multifocal atrial tachycardia because the RR intervals are pretty regular. This is not atrial fibrillation for the same reason, and so this is not junctional tachycardia because the rate is extremely fast. So what's left is atrial flutter, and that's what this looks like. Okay, now let's look at this one. Here we have something interesting here. Let's look at, we have narrow Qrs complexes. Okay, if you look at the P intervals, it looks like there are 2 P waves to each Qrs complex. There are 6 boxes from beginning of one P to the other P. So if we have 6 boxes, we are looking at a rate of 250. So this could be in the range of almost flutter with 2-to-1 conduction. If it was less than 225, then it could have been like PAT with 2-to-1 conduction. Talking about PAT with 2-to-1 conduction, we should always think about digitalis toxicity. So that's how we deduct a diagnosis. Is this atrial fibrillation? No. Is this multifocal atrial tachycardia? No. Is this a junctional tachycardia? No. So by method of exclusion, we can come to a diagnosis as to what is the most logical choice. Next, how do we treat supraventricular tachycardias that are narrow Qrs complex? As I said, we can try vagal maneuvers to at least slow the rate. If this is paroxysmal supraventricular tachycardia, it may spontaneously terminate. If it doesn't, we can give some adenosine, and we're going to talk about the exact dosages towards the end of this presentation. And again, if this is a paroxysmal supraventricular tachycardia, adenosine is quite effective in terminating the paroxysmal supraventricular tachycardia. If you are dealing with atrial flutter, atrial fibrillation, or multifocal atrial tachycardia, these drugs do not make a significant difference other than slowing the heart rate temporarily. If adenosine and vagal maneuvers are ineffective, and if the patient is hemodynamically stable, then we can try IV beta blockers and intravenous diltiazem or verapamil. And if these don't work, of course, the final option would be synchronized cardioversion. If the patient is unstable, if the patient is hypotensive, if the patient is hypoxic, don't waste any time. Get the paddles ready and go for synchronized cardioversion. Now let's move on to the next arrhythmia in the supraventricular category, atrial flutter. Atrial flutter occurs because of the presence of accessory pathways located along the tricuspid ring. There are multiple accessory pathways. They all act like a circuit that results in atrial flutter, giving this typical sawtooth appearance of this particular arrhythmia. Atrial flutter rate, I talked about anywhere from 250 to 320. 250 to 320 beats per minute. The ventricular rate can vary depending upon the degree of AV conduction. Sometimes an uncontrolled atrial flutter can have 1-to-1 conduction with a ventricular rate as fast as the atrial rate. And there are 2 types of atrial flutter. And this is the typical atrial flutter where it is going in a counterclockwise manner through this electrical accessory pathway, and thus producing these negative deflections in the inferior leads. So the rate is 300. So we are dealing with, if you look at it, involves one big box, the peaks. So that is 300. The ventricular rate is approximately 100. So we are dealing with 3-to-1 conduction. Along with that, we see these P waves here in these leads, and there are probably hidden P waves in the Qrs complex and perhaps in the T waves also. So let's look at another example, and this is the second type of atrial flutter, namely type B, where the impulse is going now in the clockwise direction through these accessory pathways located in the right atrial side of the atrial septum. And these P waves are supposed to be peaking upwards. I mean, that is, if you can imagine that, but when you see a sine wave, I don't know which one you call as up, which one is down, but nonetheless, this is type B atrial flutter. And again, we see these flutter waves, which are clearly visible. And of course, if you see classic, let me go back. If you see these classical undulations, that is type A or the typical atrial flutter. If you see these less prominent waves and more positive deflection, then you are talking about type B atrial flutter. Here, both of these side by side. This is type A flutter, where the impulse is going in a counterclockwise manner in these accessory pathways located in the lower part of the right atrium and the atrial septum. And this is type B atrial flutter. All right, let's continue. And let's look at this example here. And here we have a narrow Qrs tachycardia. Okay, let's look at the RR intervals. If you look at RR intervals, they are approximately about 10 boxes, which puts that under 150. So we have a narrow Qrs tachycardia with a ventricular rate of 150 with narrow Qrs complexes. So we are dealing with the supraventricular tachycardia. The next thing is this sinus tachycardia? Is this junctional tachycardia? Is this atrial tachycardia? Or is it atrial flutter with 2-to-1 conduction? So we have to go through these differential diagnoses. So let us see. Here we see some deflections, perhaps 2 deflections for each Qrs complex. So this cannot be paroxysmal supraventricular tachycardia. So it cannot be sinus tachycardia. It cannot be junctional tachycardia also. Is it atrial flutter? And again, you can see some P waves and P waves and P waves, all these here. So we have an atrial activity which is 300 beats per minute and a ventricular rate which is 150 beats per minute. That means we have atrial flutter with 2-to-1 conduction with narrow Qrs complexes along with T-wave inversions in the inferior leads and non-specific ST changes in the lateral chest leads. Okay, that is the final diagnosis on this electrocardiogram. So let us continue. Okay, we have another rhythm which is very similar to the one we saw before, but now look what we are seeing here. We have a very rapid narrow Qrs tachycardia. Are the RR intervals normal or variable? To a large extent, I would say the RR intervals are normal. But what is the rate? We got 6. 6 beats is 250. So 250 falls within the range of atrial flutter with 1-to-1 conduction. Could this be atrial fibrillation? Yes or no? Well, if it's atrial fibrillation, we would see a variable RR interval. Since the RR intervals are fairly constant, and there could be some few millisecond variations with a rate of 250, so this falls in the range of atrial flutter with perhaps 1-to-1 conduction. Is this PAT? No, the rate is too fast. Is this sinus tachycardia? No. Is this junctional tachycardia? No. Is this multifocal atrial tachycardia? No. Is this atrial fibrillation? No. So this is atrial flutter because that's the only diagnosis that is left. And here you can see some flutter waves, perhaps 1-to-1 conduction, and along with that we have significant ST depression. It is not uncommon to see significant ST depression when the ventricular rate is like 250. Does that mean myocardial ischemia? It could be just a functional myocardial ischemia unless the patient has underlying coronary artery disease and ischemic heart disease, and in that circumstances it may represent true myocardial ischemia. However, if you slow the heart rate down and if the ST segments resolve, then at least this may be related to the supraventricular tachycardia. All right, let's continue. How do we treat patients with atrial flutter? On an acute basis and on a long-term basis. Well, of course, this is a long-term management of atrial flutter. There should be another chart looking at acute management, but anyway, let's look at long-term management of patients with atrial flutter. Rate control and rhythm control. Rate control can be done with beta blockers, calcium channel blockers, and rhythm control, the most important approach would be catheter ablation, which has a greater than 95% success rate. On a long-term basis, we can try amiodarone, dofetilide, or sotalol, or we can also consider flecainide and propafenone in the absence of structural heart disease. Before we go into rhythm control, one of the most important things we need to take into account is the presence of thrombus in the left atrial appendage. That is something we have to rule out before we attempt rate control with either pharmacological approach, or by using cardiac catheter ablation. These patients need to be on anticoagulants for 4 to 6 weeks before any type of rhythm control is attempted. Now let's move on to atrial fibrillation. Atrial fibrillation is nothing more than impulses arising from multiple foci within the atrial musculature, resulting in a chaotic atrial activity with variable conduction through the AB node, thus resulting in either narrow Qrs tachycardia or wide Qrs tachycardia if there is an existing bundle branch block, or if the rate is too fast and if the patient develops rate-related aberration through the ventricular system. Okay, here's an example of an irregular tachycardia. The rate is approximately 70 to 80 per minute, or a little faster in certain segments. And we also have an underlying right bundle branch block, low QRS voltage, non-specific STT changes, perhaps an old inferior myocardial infarction. So we are dealing with atrial fibrillation with variable ventricular response, old myocardial infarction, right bundle branch block, and non-specific STT changes. So that's how we come to a conclusion. Is this paroxysmal sinus tachycardia? No. Atrial flutter could be, but looks more like atrial fibrillation. It's not multifocal atrial tachycardia because we don't see definite P waves here. So let's move on. Okay, here we have again an irregular atrial activity which looks like atrial fibrillation. But look at the QRS complexes. They look pretty regular here, and it looks narrow. So whenever you see a rhythm with what looks like underlying atrial fibrillation with regular rate, even though it is slower, then you always think about the atrial fibrillation with junctional escape rhythm, which means in most cases it is either related to sick sinus syndrome or drug toxicity. If these patients are on beta blockers or digoxin or calcium channel blockers, then that's what we really need to look into, and maybe get a Holter monitor and see, are we dealing with just drug-induced junctional escape rhythm in a patient with atrial fibrillation, or are we dealing with a sick sinus syndrome, which may be much more serious than just drug-induced junctional rhythm. Uh-oh, look at this one. What do we got here? First of all, we have a tachycardia. The rate is almost more than 300 beats per minute. If you look at some areas here, it's 300. So anywhere from 250 to 300 beats per minute. And the RR intervals are grossly irregular. That means we are dealing with most likely atrial fibrillation. Is this multifocal atrial tachycardia? I don't see any P waves, so it's very hard to see the P waves, so I don't think this is. The only differential diagnosis in this tracing would be atrial flutter with one-to-one conduction or atrial fibrillation. More than likely this is atrial fibrillation because of grossly variable RR intervals. The next thing is a Qrs complex narrow or wide? It's kind of hard to say with this small electrocardiogram. I would say the Qrs complexes are narrow, but nonetheless, we also see some discordant STT changes in almost all these lateral chest leads. So this is most likely atrial fibrillation with rapid ventricular response And whenever we see this type of morphology with varying QRS morphology, you always think about WPW and look for any delta waves in the normally conducted beats. We don't see any delta wave here in this tracing, but we may be able to identify in other tracings further in this presentation. All right, let's continue. Here is another example of irregular RR intervals, narrow Qrs complexes, fairly rapid rate. So this is another example of atrial fibrillation with rapid ventricular response and non-specific STT changes in the lateral leads, and also poor R wave progression in the anteroseptal region. All right, now the rhythms are getting more and more complex. Here we have a ventricular rate which is less, this may be 8 boxes here, so we're looking at a rate of 187 or 109, like 160 to 187, 170, then we have a wide QRS tachycardia. So is this supraventricular tachycardia with aberration, like left bundle branch type, or is this ventricular tachycardia? The only way to identify this would be to slow the rate down and see if we can see any atrial activity, or look for any atrial activity in the existing rhythm. There are some notches here which makes you feel they may be representing P wave. The next question is, are we seeing only one P wave, or is there a P wave buried in the QRS complexes? If this is a P wave and we see what looks like a bundle branch block pattern, then it could be a regular supraventricular tachycardia at a rate of 187, which puts this in the rate of atrial tachycardia with one-to-one conduction and of course WPW. And whenever you see wide QRS complex regular tachycardia with possible P wave, you again think about the presence of WPW. Go back and see if this patient had an electrocardiogram before and see what the findings were. Okay, differential diagnosis of atrial fibrillation should include WPW with rapid ventricular response, VT when there is an underlying bundle branch block in the electrocardiogram. Paced rhythms with no visible P waves may look like atrial fibrillation with escape ventricular rhythm. Sinus rhythm with frequent, I'm talking very frequent PACs, may look like atrial fibrillation. And similarly, multifocal atrial tachycardia, when it is very rapid, may look like atrial fibrillation. And we talked several times about different ways to look at these rhythm strips and try to exclude the most unreasonable diagnosis and come up with the most logical diagnosis. When patients present with atrial fibrillation, there are several things we need to focus on. First of all, their presentation and clinical features. Rate, rhythm, any contribution to heart failure, things like that, quality of life, all these things. But the most important thing is the rate when we're dealing with these patients in the emergency room. And the second most important thing is the presence of atrial thrombus, which can lead to stroke. Before we treat these patients on a long-term basis, we need to see if these patients are at a high risk for thrombus formation and which patients need to be on anticoagulants. Here is the CHAD S2 score, which ranks all the risk factors that will enable us to determine whether these patients need to be on anticoagulation. If the patient has a CHF with an ejection fraction of less than 40%, you give a score of 1. Hypertension 1, age 75 or greater 2, diabetes 1, stroke or TIA or thromboembolism in the past 2. Similarly, you come with all these things. If the person has a score of 2 or greater, that person needs to be on long-term anticoagulation for prevention of a stroke. Those patients who are at risk for arterial embolization through the left atrial thrombus can reduce the risk of stroke by more than 50% by being on anticoagulant treatment. Now let's switch gears and move on to junctional tachycardia. Now let's look at this one. The rate here is approximately, see if you take here 5, 6, 7. 7 means 214. So we have a rate which is 214. We don't see any P waves because they could be buried in the T waves, but there is some distortion of the QRS complex here, and this may be retrograde P waves. So we are dealing with a supraventricular tachycardia at a rate of 214 per minute. But if we use some vagal maneuvers, we may be able to separate these T waves and see if we are actually looking at a retrograde P wave, in which case we will be dealing with the junctional tachycardia. Let's move on to the next one. And here is another rhythm which is similar to the one we saw before. This is a 12-lead electrocardiogram. The rate here is approximately 160 per minute, but we see some inverted P waves here. This could be an ectopic atrial tachycardia, or it could be junctional rhythm with inverted P waves. Here's another example. We don't see definite P waves here in any one of these leads. And the rate here is approximately 166 because it's maybe occupying 9 squares. So we are dealing with a supraventricular tachycardia, which is most likely junctional because we don't see definite P waves preceding the QRS complexes. And in some occasions, we may see retrograde P waves, and that can only be ascertained if we can slow the rate to some degree. All right, here's another example, which is similar to the one we already saw. Let's look at another example here. First of all, we have low QRS voltage in the limb leads. We have a right bundle branch block here. We have some STT changes here. We have a regular rhythm, and the QRS complexes occupy 5, 6, 7, 8 boxes. So the rate is 187. So since we don't see any definite P waves preceding the QRS complexes, we could be dealing with the junctional tachycardia with a rate of 180 per minute with low QRS voltage in the limb leads, right bundle branch block, and STT changes in the anterior leads with non-specific STT changes in the lateral leads. Let's continue. Okay, junctional tachycardia. How do we treat them? Drug treatment for junctional tachycardia include beta blockers, diltiazem, verapamil, or flecainide propafenone in the absence of a structural heart disease. If these things are ineffective or contraindicated, then if this is a recurring junctional tachycardia, catheter ablation can be attempted. Differential diagnosis of narrow Qrs tachycardia we've been talking about all through this presentation, namely sinus tachycardia, AB nodal re-entry tachycardia, atrioventricular re-entry tachycardia, atrial tachycardia, flutter, and multifocal atrial tachycardia. Okay, let's talk about some accessory pathway with special reference to WPW. In patients with WPW, we have these accessory pathways located in the atrial walls, most importantly in the left atrial free wall, which can act as an accessory conduction that produces the delta wave, and when the impulse is going through the normal QRS complex, we get the remaining narrow QRS complex. Thus, this is a fusion beat resulting from conduction through the accessory pathway and also through the AB node, producing the typical delta wave in patients with WPW. And here is a depiction of the location of the accessory pathways. And this is looking at the heart, and here's the mitral valve, and here's the tricuspid valve, and they are located here most often in the lateral wall that acts as the accessory pathways. And here's an example with a delta wave, which we can clearly see in multiple leads. So this is a type A WPW because we see positive deflections in the anterior leads and also in the inferior leads. So this is type A WPW. When patients develop tachycardia, we're going to see positive deflections in the anterolateral leads. Next, and here's a similar tachycardia with a rate of approximately 170 beats per minute. And as we can see, the RR intervals are slightly variable. We have a narrow QRS tachycardia. If we see any delta waves like here, then we may be dealing with with a supraventricular tachycardia in a patient with WPW or Wolff-Parkinson-White syndrome. Okay, here is a typical example of a type B Wpw, where we have negative deflections in the inferior leads and perhaps negative deflections in the lateral leads, also producing what looks like myocardial infarction along with some STT changes. Here's an example of a wide Qrs tachycardia. That means the impulse is traveling through the accessory pathway, producing a wide Qrs tachycardia. So the treatment depends upon the morphology of the Qrs complexes. If the Qrs complexes are narrow, then the impulse is primarily traveling through the AB nodal connections, and they may be amenable to drugs that slow the AB conduction. Whereas if we are dealing with a wide Qrs tachycardia, that means these impulses are traveling through the accessory pathway, and the only drug of choice that would work in these patients would be procainamide, given either intravenously or orally, because any drugs that we give that slows the AB conduction, they can in fact make the wide Qrs tachycardia worse. So always remember A, B, C, D. Amiodarone, beta blockers, calcium channel blockers, and digoxin, all of which slow the conduction through the AB node, are not useful in patients with wide Qrs tachycardia in the presence of Wpw. Let's continue. Okay, here I just touched upon whether the impulse is going through the normal conduction, where we see narrow Qrs complex, and here's the accessory pathway, and if the impulses are coming through the accessory pathway, then it is going to create a wide Qrs tachycardia. So the treatment options are going to be slightly different if we are having what is called the orthodromic, that is going through the normal pathway, versus a circuit going through the accessory pathway, which is antidromic. All right, here are two examples put together. The narrow Qrs tachycardia, where the impulse is going through the normal AB nodal tissue, which can be slowed using ABCD drugs that slow the AB conduction, whereas here the treatment of choice would be IV or oral procainamide. For the orthodromic ABRT, we can use vagal maneuvers, and since it's going through the AB nodal connections, we can use adenosine. If the patient is hemodynamically stable, we can use the drugs which I talked about, the ABCD drugs, either intravenously, or we can also try synchronized cardioversion. If the patient is unstable, then obviously we go for synchronized cardioversion. Then for orthodromic oral drugs, which we're going to touch upon, you can just pause the video and look at these different options. All these are taken from the ACC/AHA guidelines, so it is very important for you to memorize these drugs. So I would say just pause the video or go to ACC/AHA website and download the practice guidelines for supraventricular tachycardia and keep them readily available so that you can know what drugs to use depending upon the type of arrhythmia we are dealing with and depending upon the type of conduction that is happening. So here is a long list of drugs given intravenously and through the oral route. Again, these are all taken from the ACC/AHA guidelines for supraventricular tachycardia. I am just going to mention a few of these drugs, but you have those drug names and the precise dosages, the initial dose and the subsequent doses. So you have to memorize this, and you probably want to print these and save them on your smartphones so that when you're dealing with the patients with the supraventricular tachycardia, you have a ready-made access to these particular drugs. Adenosine, you're all familiar. First you use 6 milligram IV bolus followed by 10 to 20 ml of saline flush. This can be repeated in 1 to 2 minutes using a dose of 12 milligrams, 2 doses to a maximum of 18 milligrams. Esmolol, not many of us use it, but it can be used. Of course, metoprolol can be used, which may temporarily slow the rate, but rarely does it terminate any arrhythmias as such, unless we have like oral drugs or other long-acting anti-arrhythmic drugs. Diltiazem has been used frequently in an acute situation to slow the rate and also to keep them on intravenous infusion in the presence of atrial flutter or fibrillation, which may sometimes convert the rhythm to sinus if the underlying rhythm was sinus. Verapamil is also quite useful in patients with atrial flutter or fibrillation in controlling the rate, particularly in an outpatient basis and also in an acute situation. Digoxin is not very often used nowadays, but it is an important drug, especially useful in patients with severe COPD in whom we cannot use beta blockers. Amiodarone is not as effective as an acute drug in trying to control the rate or the rhythm, but in the long run, amiodarone may be quite useful in patients with atrial fibrillation or even flutter. And so is ibutylide, which can be used, but it should not be used if the QTc is greater than 440 milliseconds. Let's move on to the next one. And these are the drugs which are used orally for long-term management of supraventricular arrhythmias. Just go through each one of these drugs, their initial doses and maximum doses, and this will come in extremely handy when you're dealing with patients in a clinical setup in the hospital or in the clinic, so that you can appropriately adjust these dosages to get the optimal ventricular rate or maybe even convert these patients to sinus rhythm. This is a continuation of the oral drugs for management of supraventricular tachycardia, and here is the link to this particular reference of ACC/AHA guidelines for management of supraventricular tachycardias. Ladies and gentlemen, that is a marathon run through the supraventricular tachycardia. This is just like a tip of the iceberg. It is an extensive chapter, but we have touched upon some very important bedside clinical clues and a systematic approach to diagnosing supraventricular tachycardia and differentiating one from the other. Hopefully this has been useful to you, and please do subscribe to our YouTube channel, and in the next presentation we will be talking about ventricular arrhythmias. Thank you so much for watching this presentation, and please do subscribe to our YouTube channel.